So, very good evening, guys. So, today we are going to discuss imaging in epilepsy. So, as you all are aware, Gulati sir has already taken a brilliant class on epilepsy imaging. So, he has covered all the theoretical aspects. So, please go and see that class if you haven't already. So, today what I'm going to do is I'll mainly focus on epilepsy protocol. Okay? So, that is mainly harness protocol that is being followed and is being recommended by the ILAE. So ILAE stands for what? So ILAE, International League Against Epilepsy. So all the recommendations on imaging and all is being given by ILAE. Okay. So we're gonna discuss the MRI protocol, the harness protocol, and then some basic MRI reading guidelines. And today I'm going to show you a lot of cases, around 20 to 25 cases. We are going to see DICOM cases. So it will be an interesting session. Okay. So you guys should keep writing the answers in the chat box as we keep on seeing the cases. Okay. So basic definition of seizure and epilepsy that can be asked in your exams. If you get a long case on of a seizure case, then this question can be asked. So seizure is a transient occurrence of symptoms or signs due to abnormal, excessive, or synchronous neuronal activity in the brain. So these definitions are standard definitions being given by ILAE. Okay. So epilepsy is what? At least two unprovoked seizures occurring more than 24 hours apart. Okay. Or one unprovoked seizure with subsequent risk of seizure of around 60% or diagnosis of an epilepsy syndrome. So these are the basic definitions of epilepsy. So today we are going to answer these questions. So first of all, who should have an MRI? Then what are the minimum requirements for an MRI epilepsy protocol, basically, and then how to evaluate MRI images and how to optimize lesion detection on MRI. Okay. The first question is who should have an MRI? So any patient who presents with first seizure, okay, and has abnormal neurological examination, meaning suppose he has hemiplegia associated with seizures, or any predisposing history like a patient with breast carcinoma if present with seizure, then obviously we are suspecting metastasis. So in these cases, MRI should be done. In focal seizure onset, okay, suppose patient is having seizures from the right upper limb. So in these scenarios, there are higher chances that you will get a lesion on MRI, right? As far as epilepsy is concerned, then again, focal location related epilepsy, in those we should do MRI, infantile spasms or seizures, changing characteristics, becoming retractable or worsening. Okay. In a child with seizure with developmental delay or developmental arrest or regression. So in those scenarios, MRI should be done when status epilepticus, right? So there are various genetic generalized epilepsy syndromes like JME or benign Rolandic epilepsy. So these are pathologies in which there are certain clinical patterns of seizures and specific EEG findings. So these are mainly clinical diagnosis. In these scenarios, usually you not get anything on MRI. So in these genetic generalized syndromes, MRI is usually not indicated. Okay. So what are the aims of neuroimaging? So what do we have to look for? So first is epileptogenic focus. What is the cause of epilepsy? Whether it's a tumor or an infective focus, what the cause is. Okay. Then identification of epileptic zone. So we use various modalities like MRI or perfusion imaging or PET-CT and try to look for what are the areas from where the abnormal EEG waves are coming, and then subsequent management can be decided upon. Then what are the relationship with the eloquent areas? So what are these eloquent areas? Anyone? What do you mean by eloquent areas? The relationship of lesion with the eloquent areas. So yes, let me look at the chat box. Just speech, motor, sensation. Right. So eloquent areas are basically important areas in the brain that directly control the functions. Okay. So any injury to eloquent areas will lead to major focal neurological deficits. So what is this? This is the central fissure. Sorry. Here we have the central fissure. So this is the motor cortex and then sensory cortex. So these are all eloquent areas. Here what we have is occipital. Whole what do we have? Visual cortex. So again, this is eloquent area. So what is this? This is Sylvian fissure. This is what? Inferior frontal gyrus, and here we have superior temporal gyrus. In the inferior frontal gyrus, you see this M-shaped area. So this is where the Broca's or speech area is located, right? So this part is called as the pars orbitalis, and this middle part is what? Triangularis, pars triangularis, and here we have opercularis. Okay, so part of triangularis and opercularis forms the Broca's area. So this is again a eloquent area. So this is what superior temporal gyrus. In superior temporal gyrus, we have this is called as the Heschel's gyrus. Okay, so this is the primary auditory cortex. This is auditory cortex. Again, this is eloquent. Here we have the Wernicke's area. This is supra marginal and angular gyrus here. So these form the Wernicke's area, and this is Broca's area. So all these areas are eloquent. So any lesion related to these areas, the surgical planning has to be it becomes critical basically. Then preoperative planning. So sequences like DTI or functional MRI, these help us in preoperative planning, right? Prognostication, whether the seizure is caused by a high-grade glioma or it's a benign lesion. So again, you can prognosticate. And then obviously follow up. Okay, so coming to the epilepsy protocol, so the ILAE recommends the harness MRI protocol. What is harness? It's harmonized neuroimaging of epilepsy structural sequences. Okay, so in this protocol, basically, we use high resolution or high contrast 3D sequences, okay, with isotropic voxels, meaning the voxels, they measure, they have identical dimensions across all the planes. Okay, so suppose this is a volumetric image of the brain. So it is formed by voxels of isometric size. Okay, so it will be 1 into 1 into 1 millimeter in all the three planes, right? So these are isotropic voxels. So advantage with isotropic voxel is that it can be reformatted into any plane. Okay, any oblique plane. You can convert axial image into coronal or sagittal or anything, right? Okay, but if the voxels are anisotropic, then you will have pixelating of images. So the harness MRI protocol recommends that we use 3D sequences with isotropic voxels. You can acquire it on 1.5 Tesla or 3 Tesla, but 3 Tesla is obviously preferred, right? And this protocol, they have recommended that it can be used in adults as well as children. So the basic thing is that obviously you need to have complete brain coverage. Because it is a 3D sequence. We don't depend on operator dependent slice angulations because for imaging of hippocampus, we'll discuss subsequently that we need to obtain it on oblique coronal planes. So because the 3D image, you can obviously generate it by yourself. Okay, so it can be reformatted in any plane without loss of resolution. So because it's a 3D sequence, there will be reduction of partial volume artifacts. So okay, so these are the advantages of harness protocol. So in harness protocol, there are three important sequences that we acquire. Each sequence lasts for around 7 to 10 minutes. So overall acquisition time usually takes around 30 minutes with harness protocol. Okay. The problem is that 30 minutes is a long time. Like in Indian setup in private diagnostic centers and all, we usually tend to finish up head case, MRI brain case in 10 to 15 minutes. So if you have to actually look for any cause in epilepsy patients, so you have to actually do harness MRI, and it's going to take around 30 minutes. Okay. Now, because of this, the neuroimaging task force recommends that in all patients in whom previous investigations were unremarkable, if the previous MRI is reported as normal, if this scan is not as per harness protocol, then it is recommended that you have to repeat the scan and use harness MRI protocol. Okay. So what is the first sequence in harness MRI protocol? The first one is a very basic sequence that we oftenly that we acquire on day-to-day basis. That is a high-resolution 3D T1 weighted sequence. So what 3D T1 weighted sequence? Usually a gradient echo sequence. It is either MP rate sequence that you all must be aware of. We always, in most of the cases, we actually acquire MP rate sequence or any 3D spoil gradient echo or 3D turbo field echo protocol. So these are related to MRI physics. We just remember right now that a 3D T1 weighted image is acquired, most commonly MP-rate sequence, and isotropic millimetric voxel resolution 1 into 1 into 1 millimeter cube, right? So what is the advantage of T1 weighted sequence? As you can see, so this is the MP-rate sequence. You can see the anatomy, the brain anatomy is quite beautifully seen on T1 weighted MR. So you can see the morphology